without much problem.
Thank you, sir.
Thank you.
Thank you, ma'am. And now we move on to the multiple pregnancy. Again, multiple problems are coming up. The lead discussant is Dr. Lekshmi Ammal from SUT Trivandrum. Our invited faculty, Dr. Sushila Rani from Bangalore, Dr. Nozer Shariar from Mumbai, Dr. Ajit S. from Trivandrum. No, I announced it right. Dr. Ajit from Trivandrum. Always his name is associated with Kannur. Now he is transferred to Trivandrum Medical College. Actually, today morning I was telling Nozer sir, our presentation, the mode of presentation has changed. We are not seeing slides made by him. We are really missing his beautiful slides in blue, which starts with a beautiful quote.
Very good morning to all of you. The topic is multiple pregnancy. In this 30 minutes, it is not possible to cover all the aspects of multiple pregnancy. So we have decided to discuss only certain aspects. Multifetal gestation, you know, it is very prone for preterm labor. Twins happen to be 3.2% of all live births and 20% of preterm deliveries. There is a 5-fold higher risk of early neonatal and infant death related to prematurity. And 50% of twins deliver before 37 weeks, and 75% of triplets will deliver before 35 weeks. So we will cover certain aspects of this preterm labor because that is something which worries an obstetrician. And definitely this is a labor congress, so our focus will be on the labor dilemmas in a twin pregnancy. And we will be confining ourselves to the uncomplicated twins only. The higher order pregnancies we will not go into, we are not going to touch. And the first question is to Sushila Madam. Madam, a 35-year-old second gravida comes to you with an ultrasound image like this. Madam, what should be your most important concern when it comes to further antenatal care?
Now, we are talking in terms of multiple pregnancy. We need to establish chorionicity because this is the best time to establish chorionicity. Now, why do we need to establish chorionicity? Because the perinatal morbidity and mortality can vary depending upon the chorionicity. A monoamniotic twin has got a lot more problems, 4 times, 5 times more problem than a dichorionic diamniotic pregnancy. In fact, 30% of all-cause pregnancy-related complications in the stillbirths are 4 times more, and even the neonatal mortality is 1.5 times more. And where you deliver, how you deliver, everything depends upon the chorionicity. That is why it is extremely important to determine the chorionicity. Complications will arise if you know what kind of chorionicity. A monochorionic will have a lot more problems like TTTS, TAPS, etc. So you will be better prepared if you establish the chorionicity. And the best time to establish the chorionicity would be in the first trimester. Between 7 to 9 weeks when we do the dating scan would be the best time. And how do you make out chorionicity? This is done by the kind of, you look at the edge of the placenta. The DCDA has a thick layer of fused chorionic membranes, and therefore it raises, you get the typical lambda sign when you know it is a DCDA twins, whereas in the monochorionic twins, because you have only 2 amniotic membranes, you get the T sign, where it is just a simple membrane taking off from the placenta. Now, supposing you miss in the first trimester, then what do you do? In the second trimester, how do you pick up chorionicity? It is possible, though it may not be as easy as what it is in the first trimester. You make out the thickness of the membranes. The thick membranes are because of 4 membranes in a dichorionic diamniotic placenta, and therefore it is more than 2 millimeters, whereas in a monochorionic placenta, the junctional membranes will be thin, less than 2 millimeters. Now, of course, you have 2 different sited placental masses. It's very obvious that it is dichorionic diamniotic. But if they are adjacent to one another, again, you can have a problem there. And another thing that is monochorionic monoamniotic twins, you tend to have the same sex fetuses. Now, but this is not compulsory, but if you have same sex fetuses, then, and if you have a very thin membrane in between, and if you have a fused placenta, you know you're dealing with the monochorionic monoamniotic twins. But beware, you need to establish chorionicity. You also need to tell the patient, if you have seen it in early pregnancy, that the twins that you see now may not remain twins. Sometimes there's something called as a vanishing twin. One of them might go away, and in the next step when you do the scan, you might be surprised to see only a single one. So that also needs to be told to the patient.
Yes. Knowing about the vanishing twin is important in aneuploidy screening also. One more twin mass in the uterus may make the blood results a little different. And now, subsequent scan at 11 weeks, you're finding it's a dichorionic, diamniotic pregnancy. No, sir, can you tell us in brief how you go about the antenatal screening, what to look for in the ultrasound scan in a dichorionic, diamniotic pregnancy in brief?
Thank you. Thank you. I'm going to start off with a quote for Dipti. Josh Billings has said there are two things in life you are never ever prepared for. Twins. Right? So as far as a twin pregnancy is concerned, a lot of the antenatal screening, care and follow-up is much like a singleton pregnancy with a few additional requirements. First trimester screening absolutely needs to be done. You have to inform the lab that you are dealing with a twin pregnancy because that has to be taken into account. If you're doing an NIPT, you have to understand that it will have to be interpreted accordingly. Just a few weeks ago, I had a XXX reported in a twin pregnancy, and then we went in for the ultrasound. The ultrasonologist had looked to see if the gender was different, and then a selective amniocentesis was performed to take that forward. Follow-ups, much about the same. Ultrasounds may be a little more frequent. We have a number of things that Sushila mentioned earlier about the complications associated with a monochorionic pregnancy. With a dichorionic pregnancy, again, we are in a better place. Your vigilance would primarily be based on two things: to watch for growth, because yes, you can have discordance even with dichorionic twins, because that's like having two pregnancies in spite of each having their own placenta, and that would have to be monitored serially by ultrasound. One important thing to understand is to identify and label each twin so that it is followed up accordingly throughout pregnancy. If the genders are different, that's not very difficult, but if the gender is the same, and if the two twins are lying side by side, then you have one which is on the left and the right, which becomes A and B, or one which is above and below, which also becomes A and B, and you have to mark this out and identify this right in the beginning. And the second very important part of surveillance is to try to survey this pregnancy to prevent preterm birth. And we will discuss this later, but we know that there's a lot of controversy which is gradually being clarified as regards the significance of cervical length, significance of symptomatology, but primarily these pregnancies will be under a radar more than a singleton pregnancy.
Okay. Sir, how often should they come for antenatal checkup, and how often should you, supposing they go uncomplicated, what should be the ultrasound frequency they should undergo?
So if basically it would be like a singleton pregnancy, so definitely every month. But if you have the slightest doubt, then they need to be called more frequently, maybe every 2 weeks. Similarly with an ultrasound, maybe an ultrasound can be repeated at every visit. But if you have a doubt, you could call them up for an ultrasound within 2 weeks, or even more frequently if required. The most important ultrasound is the one before 24 weeks. So you do most of your identifications in the early second trimester, because that's the ultrasound which is going to help you identify the twin pregnancy at a higher risk of preterm birth.
So one important point here is that if you have identified that it is monochorionic monoamniotic, the ultrasound evaluation will happen much earlier. Maybe, dichorionic diamniotic, you can take it a little easy, but this one probably you would scan once in 15 days or so.
Growth discordancy can happen even with a dichorionic diamniotic pregnancy. So the guidelines advise that they should be, once they reach the third trimester, a four weekly scan should be advised, because per abdominal examination may not always be correct. And in a monochorionic pregnancy, because of the inherent complications, ultrasound should be repeated every 2 weeks to look for growth discordancy, then your TTTS, your middle cerebral artery Doppler should be done. And supposing your picture is like this, what would you advise? A monochorionic, monoamniotic pregnancy? Madam?
Yeah, like I told earlier, when I say monochorionic, monoamniotic, and if you are working in a tertiary care hospital, this is a time I think you should shift the patient and tell her that there could be problems for her. Maternal complications can be there, fetal complications can be there. It is better that this patient is in a tertiary care center managed, where it can be managed better.
Okay.
Now, total antenatal management differs in Momo twins, because you need to look out for tabs, all the vascular abnormalities that can happen, cord entanglement can happen. You might see a Momo twins today, she is about 30 weeks, you'll think probably I'll plan and deliver her in the next couple of weeks, and you will find suddenly she comes with absent fetal movements and you get to see cord entanglement. So it is totally unpredictable with Momo twins as to how things can take place, but the best of the care needs to be given for these twins.
Yeah, there is another option, and this happened to me a few months ago. We had a monochorionic, monoamniotic twin pregnancy, obviously picked up very early. Thankfully, we are picking all of these in the first trimester. And after we counseled and spoke to the patient, she opted for terminating the pregnancy. Okay. Now, that was a choice. She decided that she didn't want to take the risk that was associated with this pregnancy. Okay. She understood what would be expected of her, and she says, you know what, I think I'm going to sit this pregnancy out, and I'm going to do it again later. And please understand that also remains an option for the patient that needs to be discussed.
Okay. So I think our time for the antenatal management is over. I think we'll have to rush through the next slides. That is preterm labor. When we get a twin pregnancy, our worry is about preterm labor, cervical incompetence. And all the guidelines say that interventions, prophylactic cerclage, progesterone, tocolytics, routine hospitalization, routine bed rest, they are not proved to have any benefit on the preterm prematurity or morbidity. And supposing no cessor, you find a patient on routine ultrasound at 20 weeks, 2 centimeter long cervix. What can you offer for her?
Yeah. So I have a bit of a problem with what was said in the earlier slide. I can understand when you say that you don't have evidence as yet, but to say they should not be used is a little harsh. In fact, many of the recent evidence is showing there may be a place for progesterone, there may be a place for cerclage, and we have to individualize on a case-by-case basis. Okay. Having said that, on an ultrasound at 20 weeks, if you have this image with a 2 centimeter cervix, basically what this is telling you is that maybe you don't need to rush in for it, but you need to put this patient under extremely close vigilance. I would always complement this ultrasound with a clinical examination. We've forgotten that clinical examinations will sometimes tell you something which ultrasound may not. And when you do a digital exam and you suddenly find that the cervix is more open than the ultrasound told you, this becomes a justification for a cerclage. I do agree that there is absolutely no place for a routine cerclage. You know, it's sad that it's being done for many twin pregnancies. It's sad for it's being done for most IVF pregnancies with twins, and there is no evidence for that. But if you take your eyes off this patient, even for a few weeks, and again I had a patient a month and a half ago, very close vigilance, everything going fine, cervix more than 2.5 centimeters, and suddenly she comes at 26 weeks, 3 centimeters dilated with membranes bulging. Now there you think maybe I should have, but you didn't. We managed to do a rescue cerclage, gave her 4 weeks more, and the twins are doing okay at 1.2 kilos each. But the importance is vigilance, 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 a clinical examination, and of course, if she's had any past history suggestive of a need of cerclage, then a history-based cerclage is absolutely justified in a twin pregnancy.
These are all what sir said. Cervical length is a good predictor of risk of preterm births, and cervical cerclage in an asymptomatic women considered when cervical length is less than or equal to 1.5 centimeter, and a cerclage is recommended with dilatation of 1 centimeter or more before 24 weeks. Now, madam, in a symptomatic patient, the guidelines say that cervical length screening has a poor predictive value for preterm birth in twins. If the mother presented, the previous was a routine ultrasound showing 2 centimeter. Now if the mother presents with on and off abdominal pain, excessive mucoid discharge, ultrasound shows 2 centimeters of cervix, what can we offer as a treatment?
Yeah, see, this kind of a situation, you have to do something, especially in a twin pregnancy. You cannot quote evidence and say evidence says 2 centimeters is okay, you can leave it in twin pregnancy, there is no. But I would definitely act upon this, and I would probably put her on progesterone, and maybe even consider if the uterus is quiescent, there is no problem at all, she's not getting contractions, I might consider keeping all other questions in mind. See, for example, I had a patient who came from an infertility center with twin pregnancy and demanded a cerclage because her clinician told her so. I said, no, there is no need to do a cerclage. I repeated the cervical length. It was around 3.5 centimeters. Suddenly, one fine day, she came and she landed up in labor. I had to do a cesarean because both were presenting by breech. Now, having said that, if she questions me again, I can always say, not all labors, not all preterm labors are due to cervical incompetence. It could be due to infection. It could be due to various other factors. That doesn't mean we need to put a cerclage for every twin pregnancy, but in this case, I would probably put her on progesterone and keep a watch on the cervical length.
Okay. I think I'll skip these things, the rest of the slides.
You
in
mentioned
antenatal care.
the mucoid discharge you mentioned.
Yes.
That's something that we often tend to neglect and overlook when patients call us up with that. And if a patient suddenly, even if it's a singleton pregnancy, calls you up and says that she's got this excessive mucoid discharge, and normally you just kind of, put her off saying that, oh, it's fine, it happens in pregnancy. Please call in that patient, do an ultrasound, do an examination. It might be your cardinal sign for the cervical dilatation. Preterm labor, I completely agree with what was said, because please understand, a cerclage is not a solution for preterm labor. A cerclage is a solution for cervical incompetence, and we sometimes confuse these two things.
So preterm labor in twin pregnancy, you can think of a straightforward cervical incompetence, but then preterm labor has other etiologies also. So before you proceed for a cervical suturing, think about the other things. Now, a patient has reached 36 weeks. What is our labor plan for her? Before that, once the patient reaches the third trimester, 28 weeks, each antenatal visit, we should be counseling her regarding a preterm labor and actually making a plan for birth if she comes in preterm labor. And she has to be told in detail about this possibility. Now, our patient has reached 36 weeks. What is our labor plan for her? The guidelines, there are a lot of guidelines, controversies.
See, if it is a DCDA twins, then we have no problem at all. We can take them right up to 38 weeks, even 39 weeks, according to the recent ACOG recommendations, as long as everything is okay. Now, when it comes to MCDA twins, up to 36, 37 weeks, once we are sure we can manage them in our NICU, it is fine. When it comes to Momo twins, of course, we want to terminate the pregnancy maximum by 34 weeks. So that is what our delivery plan would be.
Now, for twins, generally the rates of cesarean section births are increasing. We have our own reasons. But sir, what is the situation for a safe vaginal delivery? which all patients can be considered for a planned vaginal delivery.
So when you when you're working with the patient with twins antenatally, you're constantly having this conversation with her and talking to her about her options and what she's finally going to land up with. One thing I've learned is always give patients something to look forward to. So when a patient is a second trimester patient, I will say, let's get to 26 weeks. At 26 weeks, 32 weeks, telling a twins who's as it is struggling with a pregnancy, 36 and 38 weeks can be a little daunting. So keep shifting the target, but definitely try and bring her beyond 36 weeks. 38 weeks sounds well, but we know that very often a twin pregnancy, one who's dealing with babies which are probably both to normal singleton pregnancy size, is even physically extremely challenging for that woman. Forget everything else. Those pictures on the left are actual pictures from the medieval ages. So amazing that before they had ultrasound, they understood twins and they understood different positions of twins. And at that time, they had no choice. They had to bring all twins through normally and even use destructive operations whenever necessary. Today, the consensus is clear. We may not always follow it, but this is evidence-based consensus. Vaginal delivery recommended option for any gestational age. Of course, I have an issue with that because if I'm dealing with preterm twins, 32 weeks is reasonable, 34 weeks may be considered. Maybe those babies are better off with having a C-section if they are preterm. So I don't strictly agree with any gestational age. I suppose it's later. If you're dealing with a cephalic, non-cephalic, with the first being cephalic, then you could discuss the possibility of a vaginal birth if you are prepared to deal with a non-cephalic delivery, which was our previous session, which says how possible it is. Of course, the one advantage you have here is that the pelvis is tested by the first baby, that you've already had the cervix fully dilated, so there's less chance of entrapment, unless sometimes the cervix reforms, and you could consider. The one caveat here is if you've got a discordance and if the second twin is thought to be 25% larger than the first twin, then you need to do a rethink and maybe consider a C-section. And of course, you need to have people capable of it, qualified to do it, and IPV should also be a considered option in an OT. And finally, of course, there is pretty much consensus that if they are both if the first is non-cephalic, you probably go for a C-section.
Okay. Then if you think about vaginal delivery, can we induce labor? Of course, we talked about preterm labor, but if a patient goes to 38 weeks, can we induce labor? And what are the methods of induction?
So if a cervix is favorable, you pick your time of induction. If you're doing anything before 38 weeks, obviously antenatal steroids must be kept in mind. There is again, guidance saying it's not really necessary. I feel safer using antenatal steroids if I'm dealing with multiple pregnancies, and then do a rescue, a second one if required. Yes, if you can permit labor, you can permit induction of labor, because if you've understood induction and if you realize that induction probably needs to go extremely patient and at the pace of labor, why not? And I would go with vaginal PGE2 gel, and I would be very, very patient with it. I don't stop at 2, I very often go until 3. And if you've intended to have a vaginal birth, then go all the way, and yes, you can definitely go for an induction.
Okay. And what are the challenges in intrapartum monitoring of the fetus, sir?
So this is all, I mean, anyone who's sometimes even you have a woman in labor and you've tried to keep that transducer in place for intrapartum monitoring, you know that it can be challenging. And to keep 2 transducers in place in a patient who's finding it extremely difficult to lie supine because of the supine hypotension with a twin pregnancy, it is going to be challenging. But thankfully, most modern monitors will allow you to do this pretty well. And I would prefer to keep the monitor on right through labor as far as this patient is concerned. You don't keep tracing, but keep the monitor on and take periodic tracings from time to time.
And I think we'll have to rush through the next 2 slides. Madam, a word about labor analgesia?
Yeah. Preferably epidural. Any time for a twin pregnancy, if you're planning to give a vaginal delivery, epidural would definitely make a lot of difference. This is because you don't know what happens after the birth of the first baby. You can have problems with the delivery of the second one. And even otherwise, you know that the operative delivery rates can be higher in a twin pregnancy as compared to a singleton. And then if you have to do any manipulation, whether it is an exencephalic version or whether it's an interpodalic version, if you have to do any manipulation for the delivery of the second twin, having an epidural in place is definitely making it easy. And in case she needs an emergency cesarean section because of some problem in the delivery of the second twin, then it is easy to convert, shift it to the theater and do a cesarean section. So epidural analgesia would be the best choice, I would say.
Okay.
Now, yeah, there is no problem with epidural in twin pregnancy. It doesn't make any difference.
And what's the role of ultrasound?
Yeah, having a ultrasound in the labor room will make a world of difference, especially so in a twin pregnancy, because at the onset of labor, things can change. You might have known it is a cephalic presentation, decided on a vaginal delivery, but at the onset of labor, things can change. The second twin position can change. So you can check the position of the twins at the onset of labor, and then you can make sure that there is no cord in front of the presenting part, especially when it comes to the second of the twin. And there is any change in the position of the second twin you can make out. And having an intrapartum ultrasound makes a world of difference when you are doing any interpodalic version for the second of the twin. So definitely makes life easy.
And generally, obstetricians are anxious about the delivery of the second twin one. First twin delivery goes off as usual. And then how to conduct the delivery of the second twin. That's the whole idea of this topic. We have only limited time left. But sir, how do we conduct the delivery of the second of the twin?
You're definitely justified in being anxious, but the anxiousness should not come in the way of your obstetric management. Once the first twin is delivered, you've got enough time to catch your breath. You don't need to be in a rush. You're not on the clock to deliver the second twin. You clamp the cord of the first twin well. We're talking about dichorionic diamniotic twins, I suppose, and so you don't really have a worry about the fact that the placental function of the second twin will be dramatically compromised. Wait for the bag of membranes to form. Don't be in a hurry to do an ARM, particularly if the station of the presenting part of the second twin is high, if it's a cephalic. Wait for it to kind of move down, and when your uterine contractions pick up, you could have an oxytocin drip going. That's when you can do what people like to call a controlled ARM, but I believe ARMs can never be completely controlled, so you be prepared for the possibility of the fact that the cord might come down. This is best done in a situation where you can take any action. And personally, I feel that all these deliveries should be done in the OT. I believe that all these deliveries should be done with all your facilities and staff ready to do an emergency cesarean section. No matter how simple that second childbirth looks, you never know when it can go complicated. Like I said, it could just be a cord prolapse when you rupture the membranes, or if they spontaneously rupture, you could suddenly do it in the OT. The second twin not being a cephalic presentation is where your obstetric skills will be called in. I mean, which of us from our generation hasn't performed these births? It's definitely the ideal situation for those obstetric skills. Breech presentation, breech deliveries, as was shown by the earlier session, definitely is a valid option here. And even if you didn't do it here, remember all those same maneuvers are applicable in the second. And even if it's a transverse or an oblique, and if the membrane is intact and there is enough LICA, this is probably the ideal situation to either go for an external cephalic or podalic version, or then rupture the membranes and be prepared to deliver this baby by an internal podalic version. And if the baby doesn't turn, to go in for an emergency C-section. So ideal situation to practice everything that we are taught by obstetric textbooks.
I think this was the most important part of the presentation. And then I want to, actually the message to be conveyed with this talk was, in the delivery of the second twin, there has to be an active management of the second stage of labor of the second twin. Whatever sir said, do a physical examination, do an internal examination, assess the lie position, and then continue with, if the uterus is inertia, uterine inertia is there, continue with your oxytocin, and then continue with the labor. I want Ajit sir to make your comments on this, because second of the twin delivery is the most important part of the talk. And what do you have anything to say on this, sir?
As Dr. Nos suggested, anything you can practice for the second of, because the transverse lay, we can practice external cephalic version or external podalic version or even a internal podalic version. So I think just because the second of twin is a abnormal presentation or abnormal lay, we don't have to go for a cesarean section.
Okay.
And about the antepartum management also, I think I would have to say the most important thing is the assessment of the chorionicity. Yes. And the TTS mainly occur before 26 weeks. So the 16 to 26 weeks, every 2 weeks we need to do this scanning. Yep. And about the cervical circlage, I would say, we cannot say that there is no place for a cervical circlage. If the cervical length is less than 2 centimeter, I will prefer to put a cervical circlage.
Okay. Okay, sir, thank you. And then emergencies can happen during the delivery of the second twin. Madam, in short, 10 seconds for you to answer.
10 seconds.
Abruption, fetal distress,
Yeah.
cord prolapse.
So you read out the answers. One important thing is suddenly the uterus can go silent. There will be no contractions. You will be wanting the uterus to contract and deliver the second baby, and there might be no contractions at all. So you might have to start a Synto or augment the Synto in that kind of a situation. Abruption can happen, fetal distress can happen, and cord prolapse. For all these, maybe you will have to be prepared and plan for a cesarean section. If the abruption is small and if the baby is easily accessible, probably in the next couple of minutes, if you are able to deliver the second twin, that should also be okay. But everything depends upon the assessment of the fetal condition at that point of time. Yeah, having an anesthetist around to give a uterine relaxant is extremely important in the management of the delivery of the second twin. And just like what Noza said, this is something that you need to be prepared.
Okay. And then I'll skip the next 2 slides, but just one thing. Our labor room has to be either next to the theatre or it has to be an obstetric theatre. Best is
Lakshmi
to conduct
madam.
a twin delivery.
Lakshmi madam,
I
2
know,
more
madam.
minutes are added.
I know. And just one thing more. Important, what is the medical aspects? No, sir, what is the medico-legal aspect of twin delivery? This is the last question.
So I think it's already been mentioned before. If you've counseled, if you've got the patient to sign off on your planned line of management, if you've considered what her expectations are and tried to fulfill those, then I think you can be medico-legally safe. Just make sure your consent that you've taken has included just about everything that you could possibly have going wrong with the twin pregnancy. And if you've done that, then I think medico-legally you can be protected.
Okay. Sir, we'll skip the next slides and I'll wind up the session saying a thank you.